triple burden of type 1 diabetes mellitus in India. So what is triple burden? Prevalence, socioeconomic factors, and stigma. Prevalence is the rising incidence and burden on healthcare system. Socioeconomic factor includes economic constraint, access to care, and disparity. Stigma, social and psychosocial barriers affecting the disease management. Before going in detail, we should know type 1 diabetes is insulin dependent diabetes mellitus, in which the beta cells of the pancreas got completely destroyed, leading to absolute insulin insufficiency, which includes polyuria, unexplained weight loss, polydipsia, fatigue, blurred vision, and this is quite different from type 2 diabetes, as it is immunomodular beta cell destruction with absolute immune deficiency. And type 1 diabetes patients have autoantibodies, while type 2 diabetes patients do not have the autoantibodies. Both can lead to long-term complications, but the pathogenesis are quite different. So why type 1 diabetes is a public health challenge in India? Due to the low awareness among the public and providers, lack of structured education and training, inadequate infrastructure at primary level, insulin-related barriers, absence of national type 1 diabetes registry, psychosocial and socio-economic impact. Come to the prevalence and epidemiology trend. As we can see, India has the second highest number of adults, around 20 to 80 years, with diabetes in the world. India in the problem of high current burden as well as future burden of diabetes, with as per the ICMR in the day 17 study, overall prevalence of diabetes is 11.4% and pre-diabetes is 15.3%. In type 1 diabetes, India has the highest number of incidents and prevalence, with approximately 5 cases for 1 lakh per year. And here is the regional prevalence started much earlier, in which in Karnataka we can see 18 type 1 diabetes among 1 lakh children. In case of Chennai, it's quite low. And in Karnal, Haryana, it's 10 among 1 lakh children. As per the phase 1 ICMR Young Diabetes Registry, total of around 5,500 patients were enrolled. The type 1 diabetes was the most prevalent form, according around 64% of the cases. As per the geographical coverage, 8 regional collaborative centers across India with 205 repetitive centers. The top contributors are Madras Diabetes Research Foundation, AIMS New Delhi, and UCMS Delhi. The type 1 diabetes is the most common form of diabetes in youth, less than 25 years. The peak onsets in childhood and adolescence, that is less than 15 years. The diagnosed mostly based on the clinical criteria here, because due to limited availability of the autoantibody testing. And this is the clear picture of age and gender distribution. As you can see, the peak onset of type 1 diabetes is around 10 to 12, 10 to 14 years. In case of the 90% of patients are with type 1 diabetes when less than 10 years, and 77% of type 1 diabetes within the age of 11 to 19 years. As per the gender concern, the male prevalence are slightly high as compared to the female, with 51.7% male and 48.3% female. The growing burden, the future projections, infrastructure limitation, lack of pediatric diabetes services in many regions, delayed diagnosis may lead to high rate of diabetic ketosis and hospitalization. What is the need of the action? Establish diabetes surveillance system, increase of early screening, especially high risk families, invest in diabetes education, both for families and healthcare providers. So here comes the socio-economic burden. In average, the cost of diabetes management, monthly cost in urban is around 1135 rupees, while in case of rural, it is around 1072. The interesting fact is the diabetes care accounts around 19% of the total family income in case of diabetes. And the 36% higher monthly cost is diagnosed in diabetes individuals. The managing of type 1 diabetes in India is much higher. The mean annual direct cost as per type 1 diabetes patient is around 18,000 per year. The out-of-pocket share on average family paid 80%, 87% of the cost by themselves. In case of family income spent on type 1 diabetes care, the lower income family spend around 33% of their income. Most of the income spent in the insulin analog, increase the rate by 35%. High frequency home glucose monitoring. This is the breakdown of the cost component. Almost 80% of the cost goes to the glucose strip, the lancet, the meters, insulin vial, syringe, pen, needles. Rest of the 20% include the investigation, travel, food, hospitalization, and physician fee. The socio-economic disparity, that is from the lower and lower middle class to upper and higher middle class. While they spend 22,000 per year, but it equal to almost 33% of their annual income. In case of upper middle and higher class family, it is almost 7% of their income, which is a huge difference. So this is a latest study, Mysore study, which is done in Mysore, Karnataka, with a population of 113 adolescents to see how the cost affect the quality of life. Here we can see there is a strong correlation between the high cost and worst quality of life, more stress and depression, fear about the future, restricted social and school activity. This is the direct association between treatment of cost and quality of life in type 1 diabetes. The cost of care directly reduces the quality of life in adolescents. Lack of insurance in rural access barriers and heavy out-pocket expense fuel this burden. Urgent need to expand the insurance coverage, decentralize the insulin process, integrate the psychosocial support. So the impact of type 1 diabetes on children, the fear in hypoglycemia at school, children, parents, even schools are fearful of managing episodes during the school hours. School rejection and isolation is most important criteria, resulting in social withdrawal and reduced confidence in children. Social anxiety, the child felt embarrassed due to censors, insulin pumps, and diet restrictions. Parent overprotection, parent often withhold children from any kind of parties, excursion, visits, social gathering due to the fear inside them. The mental and emotional toll in type 1 diabetes, there's various type of mental ailment. The chronic stress and burnout, many individuals giving up their regular monitoring due to the exhaustion. The pre-meal anxiety and fear of sugar reading, the emotional coping and mental health feeling of guilt, depression, and low worth are common. Lack of psychosocial support, clinical prioritize clinical care, emotional needs often ignored. The body image and the self-esteem issue, social comparison leads to embarrassment and withdrawal from the social activities. The economic model of daily lost, the poorly managed uncontrolled type 1 diabetes leads to early mortality, mostly in case of rural and uninsured cases, severe complications like retinopathy, neuropathy, chronic kidney disease. The global studies estimate around 50%, up to 50% of type 1 diabetes deaths are preventable with timely insulin access, which is quietly huge. Children and adolescents with underdiagnosed type 1 diabetes may lose 10 to 20 years of their healthy life due to late managed and late diagnosed. The hidden cost of type 1 diabetes, which is beyond the medical bills, the quality of life lost almost up to 20 years if late or misdiagnosed, the preventable hospitalization, the diabetic ketosis admission due to missed insulin with high ICU usage, direct cost around 27 to 35K per year, with insulin and strips costing around 80% of the cost, caregivers job loss, missed school asset sales, intergenerational impact, the loss of productivity, education, increased long-term poverty risks, and that is the most important and sensitive part, the stigma and psychosocial aspects. Social stigma manifests through exclusion, blame, negative socio attitude, the normalization of societal judgment creates profound emotional challenge. Stigma also directly impact the healthcare access with self-management. The insulin stigma, the myths around the insulin use, many family believes insulin causes dependency, addiction, or organ failure. Many caregivers delay the insulin initiation, fearing that it is the last or this is the end and it is a terminal end of disease. Stigma especially strong in rural areas where insulin is viewed as a last hope. Insulin literacy and awareness, we can do it at least. Start the education and diagnosis, begin insulin and glucose monitoring education immediately post stabilization. Hands-on family involvement, practice technique to reduce the fear and build confidence. Use multiple platforms, clinics, schools, social media, and support groups. Consistent messaging. All educators should convey uniform guidance. Myth busting that insulin is not addictive. It is just a choice and pattern. The mental health burden, around 78% of the type 1 patients with depression report stigma. Children and adolescents with type 1 diabetes often experience exclusion from the activity due to dietary and injection needs. Labeling as the sick child, parents with type 1 diabetes have the highest reported stigma of up to 83%. Type 1 diabetes is frequently concealed during marriage and proposal, especially in case of women. Women with type 1 diabetes face greater scrutiny, particularly in traditional settings. Fear of being perceived as a sick and incapable childbearing leads to hiding the diagnosis, avoiding the insulin use in public, leads to very severe complications. While 38% of type 1 diabetes individuals felt judged, a 42% of female with type 1 diabetes felt emotionally impacted by stigma. The lack of awareness in the society, that is the main is confusing between type 1 and type 2 diabetes due to the basic unaware of the knowledge, thinking diabetes is caused by lifestyle choices, believing it is contagious or due to personal failure. So how the stigma shapes the life of the type 1 diabetes? In social school environment, the most commonly the child will feel bullying, hiding devices, exclusion from group activity. In marriage and relationship leads to concealing the diagnosis, fear of rejection, pressure on women. The mental health like depression, anxiety, burnout, self-stigma are more common. Public awareness, the key impact will be type 1 and type 2 diabetes confusion, cultural myths, lack of empathy. That is the way forward and the strategic priority we can do to improve the type 1 diabetes care and improve the burden in India. So need for the policy level changes, free and universal access of insulin and glucose monitoring tools is essential to reduce the mortality and prevent complication. Establish pediatric endocrinology units in all district level government hospital to manage the youth onset of type 1 diabetes. Include type 1 diabetes management under existing national health program. Expand coverage under Ayushman Bharat and state schemes to include the chronic insulin therapy. Integrating the type 1 diabetes in school health program, train the teacher and the school staffs on hypoglycemia and recognition and immediately response, basic insulin knowledge, provide on-site glucometer, glucose tablet, and provide insulin use space in schools, promote a non-discriminatory school policy to protect the children with diabetes. Public health campaign should be focused on myth busting around insulin use, type 1 diabetes causes, and long-term management. Poor early diagnosis through growth chart deviations, polyuria, and school screening. Use digital media apps, short videos, and grassroots methods by educating ASA, school fairs, ANMs to raise the awareness. This is the conclusion, the area and the action required in healthcare system. We should prefer free insulin pediatric endo access in all district. In school, the staff training on-site glucose kits, no exclusion policy. Public education need to beat the myths, teacher early science and multi-channel campaign. In community, where we can empower the ASA, the NM, build family-focused education models. Research and innovation, genetic training in Indian population, teplizumab trials, affordable tech solutions. With all this, we may decrease the type 1 diabetes burden in India. With this, I conclude my talk. Thank you.